all know that heart failure is a clinical diagnosis. What is important is 4 specific issues in the management: ejection fraction, ischemic versus non-ischemic, and scar versus no scar, and the etiology of the heart failure. So these are the 4 things that we would like to evaluate. In the etiology of heart failure, as you can see, that there is a huge number of diseases, and as Dr. Uni put it very well, India has almost all these diseases in various parts, in various proportions. There are a lot of options in evaluating heart failure. However, I will try to focus my discussion on cardiac MR, which I think is a very, very important tool to diagnose heart failure. This is our MR lab, and you can see we have a large volume of cases. Almost 40% is ischemic heart disease, and we do have the other diseases as well. Now, why MRI? Now, if you look at the competing technologies, you will see that every facet of cardiac function is taken up by CMR, and you can see the white line, whereas the other modalities have some limitation of the other. And so we call it the one-stop shop for imaging. The most important thing, as again was discussed, was in a patient with heart failure, you need to differentiate whether the patient has a reduced ejection fraction versus a patient with a preserved ejection fraction. And the cardiac MRI is today the gold standard. Using the modified Simpson's rule, we have no issues about window, we have no issues about patients who are obese or deformed ventricles. And you can see how crystal clear these images look. We get 8 sections, and we get the ejection fraction, the mass, the end diastolic, end systolic cardiac output, and the stroke volume. So ejection fraction, whether it's the RV or the LV, cardiac MRI is the gold standard. If you look at the 2013 recommendations, cardiac MRI at every aspect of heart failure is highly appropriate compared to the other techniques. The second aspect when we look at patients with heart failure is whether this patient has coronary artery disease or no. Now, it is important because if you look at Felker's data, that anybody with an ischemic heart disease, the lines diverge quite early in the progress of the disease, and you find that patients with ischemic heart disease have a poor prognosis. And what have we been doing till recently? Well, we've been doing angiograms, and you can see the right patient has a significant lesion in the LAD, there's a stent there, and the patient on the left has a normal angiogram. Well, you can do that. However, MR I think does a better job because it's based on the wavefront theory. And if you have a scar on the MRI which has a subendocardial reaching out to the epicardium, it is an ischemic etiology. Whereas if you have a scar in the mid-wall or in the epicardium, it is non-ischemic. It's a very beautiful non-invasive way of differentiating both, because we have patients, in fact a couple of patients who have an underlying dilated cardiomyopathy, they are smokers and they have lesions. So we really don't know, just because the angiogram has lesions, is that the cause or is that the bystander? If you look at the 2009 guidelines, a non-invasive imaging, especially MRI, has a 2B in ruling out coronary artery disease, but it also has a 2A recommendation in a patient with coronary artery disease to look for viability. So it's definitely not 1, but it's at least a 2A. Now, what is the role of cardiac MR in coronary artery disease? Well, the important thing is to look for wall motion, and you can grade it very well on the MR. And as I said, all the sections are seen very, very well. It is not operator dependent. We can look at perfusion both during adenosine stress and at rest, and you can clearly see the decreased perfusion in the LAD territory here. Then we can look at the delayed enhancement, and in white in MR is dead tissue, and we can grade this gadolinium enhancement based on the American 17 segment model into normal, which is white, and more than 50% transmural, which is in dark blue. And then we put it together and we come to this kind of a table. So we have a wall motion, we have a gadolinium enhancement in the same thing, and then we get the viability. And you can clearly see that those segments which are in pink, which have a wall motion, which have gadolinium enhancement more than 50%, are completely non-viable. And generally, if you have more than 50% of the myocardium as non-viable, the patient is unlikely to do well. What about PET? PET is a close competitor to the cardiac MR, and it is actually more sensitive. However, data has shown that even if you have a little bit of PET here, PET uptake, if the thickness or the thinness of the myocardium in that portion is less than 4.5 millimeters, the recovery is going to be less than 13% compared to if on MRI the thickness is more than 4.5, then there is an 85% recovery. So thickness and thinness is very well seen on MR. PET simply doesn't have the resolution to look at it. And we all know the importance of viability despite a couple of studies, small studies which really didn't show much effect. But if you look at Allman's data, you can clearly see it is very, very important to differentiate patients with CAD and heart failure into the viable ones and the non-viable, because if you revascularize the viable patients, they do very well. The mortality is extremely low compared to those patients who are left on medical management. What about post-MI complications? And you can clearly see here that severe MR, post-MI, myocardial rupture, which again is a very gray area in 2D echo, and also the presence of aneurysm and thrombus early after MR can be distinguished very well on the MR. And when we do the delayed enhancement on the C3 patients, you can see that the patient with the rupture has an area of microvascular obstruction with a total scar. You can see the clot extremely well, and you can see that the cause of the mitral regurgitation is a scarred lateral wall, which is transmural and is unlikely to get better with revascularization. This patient needs a ring or a mitral valve replacement. What about valvular heart disease and heart failure? In the latest guidelines in the 2017, for the first time, the American Society of Echo has deemed it fit to collaborate with the SCMR to form their guidelines, showing that cardiac MR is a very important conjunctive tool to be used with echo. So when it comes to aortic valve assessment, when you look at cardiac MR versus 2D echo, you can clearly see that there is both are quite equal, and it is especially more important if there is a very deformed calcified valve which 2D echo cannot look at. Regurgitations are very well seen on MR, and the biggest advantage here is the quantification, and especially the fraction, more than just the regurgitation volume, the fraction. And you can clearly see that putting a VEC code here in the ascending aorta, you can get this very, very good data set. That's the forward flow and the regurgitant volume, and then you get the regurgitant fraction, which is very, very easy to do, unlike echo, which can be a little laborious, especially if it is in the moderate severity. Now, what about mitral stenosis? Echo is a very, very good tool. However, if they are calcified and deformed valves, then cardiac MRI is a very good adjunctive tool to be used. And you can see there is a very good correlation with transthoracic echo and cardiac MR in mitral stenosis assessment. What about mitral regurgitation? So not only the cause of mitral regurgitation, you can see the scar here, it's a transmural scar, but also the quantification of mitral regurgitation. So we look at the stroke volume, and then we look at the flow across the aortic valve, and then the flow across the aortic valve is subtracted from the stroke volume, and that gives us the mitral regurgitation. A very, very simple and easy formula that you can use, and this is very, very accurate, as good as 3DT for the quantification of mitral regurgitation. And most importantly, it shows us regurgitant fraction, which is possibly a better marker than regurgitant flow. Now, what about constrictive pericarditis? Echo is a very, very good tool to diagnose it. However, you can see that MR shows it very beautifully. The concept of ventricular interdependence can be seen very, very clearly. The thickness of the pericardium can be appreciated very well. And what is most important is when we give gadolinium, you can see this whole area in white is nothing but pericardial enhancement. And why is it important? Number one, you diagnose the disease, constrictive pericarditis. But if you look at this article, and this is what we've been following, is that if there is significant hyperenhancement, then these are patients who have an inflamed pericardium who do very well with steroids, and after 4 weeks, we repeat the cardiac MRI, and if the delayed enhancement comes down, you find that the features of constriction also come down. So that means every patient of constrictive physiology does not need to be sent to the surgeon. In congenital heart disease, any complex heart disease or extracardiac abnormalities causing heart failure can be very well visualized on the MRI, and the detection of coarctation severity, especially if it is interdependent, is actually more accurate on MR because it doesn't depend on the Doppler flow angles. Now, the biggest area which I'm going to be covering, and I have 9 minutes to do that, is the area of non-ischemic cardiomyopathy or structural heart disease, which is non-ischemic. And you can see the table has a wide variety of diseases, and I'll try to do justice to some of them. Now, why is it interested to know etiology? And Dr. Ponde himself admitted that when it comes to etiology, MR is the gold standard. And the reason is that each and every non-ischemic cardiomyopathy is not the same. You can see that the dilated cardiomyopathy, for example, has a much better prognosis than that of hemochromatosis. So it's very, very important to go to the root of the etiology. It's good to diagnose non-ischemic on the echo, but then we need to go further. And the MR has gadolinium, which has a very, very interesting pattern. In fact, very specific patterns for different diseases. I'll come to them when I talk about it, which can clearly differentiate them. Now, what about prognosis? The moment you have a scar in blue, the all-cause, the heart failure hospitalizations, and the sudden cardiac death go up manifold, and scar evaluation is there only on cardiac MR. What about etiology? Every disease of the heart, as you know, if you take a biopsy, by endomyocardial biopsy, and subject it, you need multiple stains to distinguish different diseases. So different diseases, different stains. But we have a solution. This is a fairly new protocol that some of us have started doing in India, and it is well established, especially in Europe and the United States, is the T1 mapping. And the beauty of this, it is non-contrast. So as you know, many of our patients with heart failure have borderline kidney functions, and it's sometimes difficult to give them gadolinium. It's not very safe because of NSF, nephrogenic systemic fibrosis. So we have developed a technique called a T1 map, and this is a beautiful picture it gives without giving a drop of contrast. And that also means safety. It also means less time in the scanner, and more importantly, in Indian context, it means less cost because you're not giving any disposable. So the use of T1 mapping grades a large number of non-ischemic cardiomyopathy from a low T1 like iron and Fabry's disease and lipid diseases to amyloid, which is in the other extreme. And I'll just give you some examples. Now, is it really important? It is. Not only it gives us the kind of disease, but also tells us about prognosis. So if you have a higher T1, prognosis survival is lower. We also are able to calculate extracellular volume based on the T1 mapping. And if you have a higher extracellular volume with the same ejection fraction, you do have a worse prognosis. What about T2 maps? T2 maps again have a thing with gadolinium. So more of gadolinium, more of T2, and therefore a worse prognosis. Now look at this patient. This patient is, I think, clear to everybody. It's a dilated global hypokinesia, severe LV dysfunction. What is more important is the presence of the mid-wall scar. And does that make a difference? Because the echo can diagnose DCM very well. But once you have a scar, you're talking about prognosis. The moment you have a scar in this patient, for example, there is a significant mortality in this patient compared to a patient with the same ejection fraction, same volume, but no scar. So the all-cause mortality and the cardiovascular mortality immediately diverge once you have a scar. Someone mentioned about postpartum cardiomyopathy. We have a fairly large series of single center experience with postpartum cardiomyopathy. So all these women, after a month after the delivery, we do a cardiac MR, and what we do is we give gadolinium, and it is safe once in the postpartum period. And if this patient has no scar, the prognosis is good. And what is more important is that there is a chance that you can give this lady a second attempt at pregnancy, which is very, very important in the Indian context. What about ARVD? ARVD, I believe, is a diagnosis completely dependent on MR. So whether it's the typical outpouching and dilated RV, which is seen very well, or if it is the scarring of the RV free wall, or it is the fat deposition, all three features are seen very well. And if you look at the latest guidelines, there is some very, very objective guidelines which have come in, and which is more than 110 ml body surface area for a male, more than 100 for a female, and a less than 40% ejection fraction. Ejection fraction of the RV is again something which is unique to cardiac MR, and 3D echo is just coming very close. Now, hypertrophic cardiomyopathy, again you can see no points for guessing this. Echo can show that very well, the mitral regurgitation, the septal. But what is more important in terms of prognosis is when we do the gadolinium and show the tissue characterization, you can see this patchy scar here, and now we are beginning to get data. It's not in the guidelines as yet, but if you have more than 15% of myocardium scarred, these are patients at very, very high risk of sudden cardiac death. So in our institute, we are moving towards using AICDs in them. What about myocarditis? Again, these are patients, young patients come to the ER, TROP-T is positive, ECG changes, you do an angiogram, they're normal. These are actually patients with myocarditis. We have, again, a fairly large series. We do a lot of cardiac MRs for them. And you can see this patient who's come in with heart failure, and you can see the edema there. It's a patchy edema, not corresponding to vascular territory. And also there is a midline scar, very, very classical of myocarditis. And why is it important? It is important because now we have the tools like a T1 map, which if you look at the area under the curve for gadolinium, for T1, for T2, T1 map has the highest area of under the curve, and therefore is the most sensitive tool to pick up myocarditis. And again, as I said, it's a 15-minute sequence, no contrast. And myocarditis is very important because most of them is because of just two viruses, the herpes virus and the parvovirus. But in a good number of patients, you get a biopsy negative. So cardiac MRI is basically a virtual biopsy, and by doing a cardiac MRI, you can make the diagnosis and put this patient on immunosuppressants. Again, no guesses for this, but this is a case of dilated cardiomyopathy referred to me for a TIA, and you can see how we're able to make the diagnosis of non-compaction so well. I'm sure the echocardiographers can do that, but this is so easily and well seen, and we have a separate criteria of 2.3:1 in diastole compared to the echo criteria, and we know that long-term anticoagulation is important. Moving on, you can see this is a cardiac MR picture of significant mediastinal lymph nodes. This patient came with ventricular tachycardia and heart failure, and there is obviously LV dysfunction, but what is more important is a midline scar here and an epicardial scar here, which is again very, very typical of sarcoid. This patient underwent a PET scan incidentally, and you can see that there is significant uptake in the lymph nodes and there is a significant myocardial inflammation. And cut to 3 years later, patient has been put on immunosuppressants. You can see all the nodes have disappeared on the PET scan and there is no inflammation in the myocardium. This is one of the cases of our own series, and it clearly shows that if you have a delayed enhancement which is significant, there is significant mortality in patients with sarcoid compared to those without. And this is our paper that we have published regarding ventricular tachycardia and the role of sarcoidosis, and there's a significant number of our patients who come for VT, come for devices actually, but we rule out sarcoid and tuberculosis, treat them medically, and they do well. Amyloidosis was again a death knell for most of our patients, but you can see here you can do a virtual biopsy. You don't need to take any biopsy from anywhere. The classical subendocardial global scarring is important, but once you use a T1 map, you can clearly see that the T1 numbers are very, very high compared to normal patients. So you can actually just on a T1 map make the diagnosis of cardiac amyloidosis, which is sometimes very difficult to do on the echo. And what is more important is to look at the disease, how it goes after treatment with borotezumab. And you can see here there's a patient with pre-chemo and there's a patient with post-chemo. The entire delayed enhancement has actually disappeared, and the T1 maps look much better. So it is useful for prognosis, it's useful for following up the disease. Now iron, MR is very good. A magnet, as you know, has got very good affinity to iron. So we call the T2 star imaging technique as the myocardial thalassemia INR. We find a lot of patients coming with high ferritin values, but this is a patient with a high ferritin value, lot of liver uptake of iron, but there is no iron in the myocardium. And this is another patient with a similar ferritin level, which a lot of myocardial iron and no uptake on the liver. So cardiac MRI is like the biopsy tool for iron, and again it does not require contrast, hence it is very, very safe and easy to use. Again, a case of EMF, Dr. Uni has been talking about it, and MR is very, very diagnostic for it, and the delayed enhancement has got a very beautiful apical kind of delayed enhancement, which is classical, you don't need to do a biopsy. Fabry's disease, again, we are getting a lot of patients with LVH, and you can distinguish them on MR. What about cardiac masses? This is a patient with no guesses for this, hydatid cyst, and MRI is highly appropriate for the use of cardiac tumors. And this is another patient who was referred to me by echocardiographer with a large mass, you can see here. But with the MR, we have not only diagnosed this to be a thrombus by a delayed technique, but we have also shown a significant involvement transmural scar of the LAD territory. So it is not only a thrombus, but we know the origin of the thrombus. So I will conclude, ladies and gentlemen, that the evaluation and management of patients is clinically very, very challenging. However, essential to the appropriate care, apart from clinical evaluation and echo, is to identify morphology and function, which MRI does very well. And what is even more important is the identification of pathologic as well as modifiable substrate, which you can modify by either device therapy or medical therapy. Thank you very much.